Good evening, everyone. How are you? Hope you're doing good. Today, I'm going to talk about one of the important topics, that is goal-directed use of obesity medications in adults with obesity-related diseases, which is an ADA framework, American Diabetes Association framework. So let's go into this very interesting topic. So what this framework provides? It talks about when to use the obesity medications. When we have to use the obesity medications, the correct indication is that when the BMI is more than 30 kilogram per meter square, or when it becomes 27 kilogram per meter square associated with the comorbidities. So that is the correct indications that we have to start the obesity medications. Then talks about the which medication to be preferred based on the comorbidities. It talks about the strength of evidence for each outcome, and whenever the response to obesity medication is inadequate, then how to escalate the treatment. And the core philosophy of this framework is that we have to treat the obesity as a chronic disease like diabetes and hypertension. And we have to select anti-obesity medications based on the dominant clinical goals and complications. So before the medications, what is very important is foundational lifestyle therapy. It applies to all the patients. It is required before and alongside while we are using medications. And obesity medications do not replace the lifestyle intervention. Let's talk about the foundational lifestyle therapy in detail. And before any medication, as I told, all patients should receive the comprehensive lifestyle intervention, which includes core components like behavioral counseling, which further includes goal setting, self-monitoring, problem solving, lapse prevention. Another important component is healthy nutritional pattern, which is individualized, sustainable dietary approach, calorie deficit appropriate to goals and comorbidities. Then we have aerobic and muscle strengthening activities, which improves your cardiometabolic health independent of the weight loss. Next important thing is self-monitoring. The patient has to self-monitor their weight, diet, and physical activity. Then the patient has to avoid the weight-promoting medications whenever possible. Whenever the alternative exists, they have to avoid the weight-promoting medications. Example is steroids, some antipsychotics like olanzapine, insulin, and sulfonylureas. Then follow-up frequency, how often and how long we have to visit your doctor. Monthly for the first 3 months, then every 3 months for the first year, then at least every 3 to 6 months long term. So what is the goal of this framework? Is improvement in the obesity related diseases and complications according for achievement and maintenance of the weight reduction. So what is the key idea of this framework? Weight loss is not the only endpoint. We have also should treat the comorbidities. So improvement in the diabetes, hypertension, cardiovascular disease, sleep apnea, liver disease, they are also equally important. So obesity related conditions, each condition is shown as a separate clinical pathway with the medication chosen based on the evidence of benefit for the condition. So what are the conditions or comorbidities listed? We have prediabetes, type 2 diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure with preserved ejection fraction, metabolic dysfunction associated with steatohepatitis, obstructive sleep apnea, and osteoarthritis. And meaning of evidence labels, each medication is labeled either with the category A, B, or C. What it denotes, A means demonstrated benefit. We have high quality evidence and that direct benefit for that specific outcome. The drug is very effective. Then comes the category B. It shows potential benefit, moderate evidence is there, likely benefit, but less robust data. Then comes the category C, potential benefit, lowest certainty, there is limited or intact evidence. And medications are listed in the descending order of the benefit. The best drug is placed first. So let's talk about the condition-specific pathways. First one is prediabetes. So what is the goal in the prediabetes? We have to prevent the progression to type 2 diabetes. The drug which shows the category A, demonstrated benefit, highly effective is tirzepatide, semaglutide. The drug which shows moderate evidence with the category B is phentermine, topiramate, and liraglutide, orlistat. The rationale behind that is GLP and GIP-based therapies, they are mostly reduce the diabetes progression. Other agents, they help mainly through the weight loss. Next comes type 2 diabetes. The drug which shows demonstrated benefit and very good evidence is tirzepatide, semaglutide, liraglutide. And drug which shows the category B is phentermine, topiramate, naltrexone, bupropion, orlistat. Then comes ASCVD. The major goal is to reduce the major adverse cardiovascular events, MACE events. The drug which shows very good benefit or demonstrated benefit with the category A is only one drug, semaglutide. The drug which shows the moderate category B is liraglutide and tirzepatide. The key insight is that not all glucose-lowering drugs reduce the cardiovascular events. Only the semaglutide has shown the potential evidence in reducing the cardiovascular events. Then comes hypertension. The goal in the hypertension is to reduce the blood pressure. The drug which shows demonstrated benefit with very good evidence are 3 drugs, tirzepatide, semaglutide, and also orlistat. The drug which shows moderate evidence belonging to the category B is phentermine, topiramate, and liraglutide. Weight loss itself lowers the BP, but GLP-1 based agents, they show more consistent reductions in reducing the BP. Then comes heart failure with preserved ejection fraction. The goal here is to reduce the heart failure events. The drug which shows very good benefit, demonstrated benefit in the category A is only one drug, semaglutide. The drug which shows the moderate category B is tirzepatide. The weight loss produced by semaglutide improves the exercise capacity, symptoms in the heart failure, and quality of life in the heart failure with preserved ejection fraction. Then comes MASH. The goal here is to improve the steatohepatitis. The drug which shows demonstrate benefit with the category A is only one drug, semaglutide. The drug which shows moderate and potential benefit belonging to the category B is tirzepatide, category C is liraglutide. The liver fat reduction correlates strongly with the weight loss and insulin sensitivity. Then comes obstructive sleep apnea. The goal here is to reduce apnea-hypopnea index, AHI. The drug which shows demonstrated benefit with very good evidence belonging to the category A is only one drug, tirzepatide. And drug which shows potential benefit with moderate evidence belonging to the category B is liraglutide, and less evidence with category C is phentermine and topiramate. Tirzepatide shows the most robust improvement in reducing the apnea-hypopnea index via substantial weight loss. Then comes osteoarthritis. The goal here to reduce the pain. No drug has shown the category A. The drug which has shown potential benefit with moderate evidence belonging to the category B is semaglutide, and with less evidence, the category C is tirzepatide and liraglutide. Here the evidence is indirect and pain reduction. How it is happening? It is mediated through the weight loss and because of the reduced joint load. Next comes the medication selection principle. And we have to select the obesity medications that aligns with the individual goals, and it should not present barriers to its long-term use. So what is the barriers? The barriers may include side effects, cost, insurance coverage, route of administration. Some people don't prefer parenteral injections like subcutaneous injection. They want only oral. So patient preference and contraindications, they are the main barriers. So what to do if the response is inadequate? We have to do the treatment intensification. So if weight loss or complication improvement is insufficient, consider increase the dose to maximally tolerated, that is within the approved limits, or you can switch to an alternative obesity medications, or you can combine the obesity medications with intensive behavioral therapy, or you can add another obesity medications, or you can continue the medications and refer them for bariatric surgery. So this reinforces obesity as a stepwise chronic intensifiable treatment model similar to hypertension and diabetes care. Thank you so much for your kind attention, and kindly share my lecture to your friends.